So now I'd like to go through just a few examples of some cohort studies to give you a better sense as to how these studies look and how they are designed. So this is an older study published in 1981 to assess the effect of passive smoking on health effects. The data were collected across 6 different prefectures, which are similar to states in Japan. The authors were interested in studying the smoking habits of spouses of 91,000 non-smoking wives and 20,000 non-smoking husbands. So this illustrates the general study design. It began in 1965, and it categorized people according to their exposure to secondhand smoke, either exposure or not exposure. And then it followed individuals for 14 years to then assess for the outcome, of which included death, and death was assessed by death certificates. So this slide illustrates the relative risk data for death among women who were non-smoking and were married to men who were smokers. And this figure illustrates a clear dose response with respect to the increased risk of death associated with increased number of cigarettes smoked by spouse. Now, what's important to note in this figure is that the reference group is the non-smokers. And so to interpret these bar graphs, one would say, for example, with the 1 to 14 cigarettes per day, we can say that the relative risk of death is 1.4 times greater among women whose spouses smoke compared to women whose spouses do not smoke. Again, it's very important when you're interpreting data that you determine and understand what the reference group is so that you interpret the measure correctly. And then this is the same data for the males of smoking wives, again illustrating a dose response. And then this is looking at data of a similar sort, but this is a hypothetical scenario, and the purpose here is to show that relative risk is a relative measure. So these are just data that were made up and essentially provide you with different incidences of the outcome, say mortality, according to the exposure level of secondhand smoke. And then we could calculate relative risks accordingly. So for example, if we're interested in the relative risk of those who are with spouses who smoke at least 15 cigarettes a day compared to women or individuals whose spouses do not smoke, we can take the ratio of the two incidences, so 20/2. Again, these data were made for you, so it has a perfect same denominator. And we get a relative risk of 10. So that relative risk is saying that, again, the risk of death among among individuals whose spouses smoke at least 15 cigarettes a day is 10-fold greater than that among people whose spouses don't smoke. You could also look at it as a relative measure among those whose spouses ever smoked compared to the spouses who don't smoke. And here you get a relative risk of 4.2. So again, depending on your question, your relative measure changes, right? And then you could also ask, well, what would be the relative risk if we had a different reference group? So in this instance, we've combined the occasional, quitter, and never categories to serve as the reference against the group of people who have spouses that smoke less than 5 cigarettes a day. And here you get a smaller relative risk of 1.5. So in summary, the interpretation of a relative measure, such as a relative risk here, must account for what serves as the reference group and also what is the category of exposure that is being considered. In this particular hypothetical, we have multiple exposure groups, which can certainly be the case in a lot of cohort studies. Another example is from England. This is also a bit of a dated study, but it's a simple cohort example. This was a study to assess for the risk of cardiovascular disease associated with exposure to an oral contraceptive. And here they studied 23,000 oral contraceptive users, and those users were then matched with a similar group of non-users, and they were matched by age and marital status. This illustrates the general design of this study. Again, they had 23,000 users and 23,000 non-users, and they followed them for morbidity and mortality all the way through 1981. This figure illustrates the relative risks of the specific outcomes that they studied. And in these figures, the reference group would be the non-oral contraceptive users. So to interpret one of these figures, we can say, let's take heart disease, which has a relative measure of roughly 5.5. In this figure, we can then conclude that the relative risk of heart disease is 5.5 times greater among oral contraceptive users compared to the risk in individuals who do not use oral contraceptives. Another study is a hepatitis B cohort study. This was started in the 1970s in Taiwan, and the question was, is hepatitis B etiology associated with primary hepatocellular cancer? And they studied over 21,000 male Taiwanese members of the civil government. Here's just an illustration of the design. In this particular study, the exposure group was presence or absence of the hepatitis B surface antigen. And given the prevalence of that surface antigen wasn't tremendously high at the time, you notice here that the number in the exposed category is quite low compared to the number in the unexposed category. However, that's okay. That happens oftentimes in cohort studies where the numbers in the unexposed greatly outnumbers that in the exposed. Similarly, the number of cases was low overall, of only 161 cases, but sufficient numbers in order to calculate a measure of relative risk, which is shown here. And if you throw in the numbers, you calculate a relative risk of 94.1, which is tremendous. And this basically is saying that among people who have the hepatitis B surface antigen, the risk of hepatocellular cancer is 94 times greater than the risk in those people who don't have the surface antigen. And granted, this study is dated. We now know that hepatitis B virus is a major risk factor for hepatocellular cancer. And then another example is that from a more recent publication looking at the relationship between serious cardiovascular events and the exposure to ADHD drugs. This was a retrospective cohort, which is a cohort study that's essentially using data that already exists. So it's still a cohort design in that it begins with the exposure groups and then observes for the occurrence of the outcome. But the only difference is that the data already collected. So this study included over 1.2 million persons, and the outcome was a combination of cardiovascular death, myocardial infarction, and stroke. And slightly different analysis here than what I've presented so far, which this included a hazard ratio. And really all you should know about that at this point is it's kind of like a relative risk, except it's accounting for time to event. But we would interpret it in a similar way as we do to a relative measure of risk. So despite the fact that this particular cohort had a tremendously large number of persons and person years, the overall event rates were rather low or small. And specifically, there were only 7 events among confirmed current users of these medications. And that was out of 373,000 person years. But nevertheless, they were able to calculate a measure of risk. And they essentially calculated a relative measure that suggested that there was no increased hazard or increased risk of any of these outcomes associated with exposure either currently or previously to an ADHD medication. And this was despite multiple sensitivity analyses to assess for roles of different factors that may have influenced the findings. Now, this study was driven by a question as to whether or not these drugs increase these risks. And the current belief is that, based on this study and other studies, that these products don't increase the risk significantly. However, the major criticism of this particular study design was that it was confounded by indication. What that means is it's a study where it's already designed to lead to biased findings. And we'll go into this a little bit more when we discuss confounding and bias in future lectures. But this was a criticism of the study, but in my opinion, this criticism isn't significant enough to refute the findings. So just a couple of points about relative risks and risk difference and some notation about those. This slide just provides you with some ways to think about these measures using a different form of notation, largely probability notation. The idea is the same as before. Here, probability would be the same thing as risk. And just essentially just illustrating another way to think about these measures. Now, once again, risk difference is the differences of the two incidences between the exposed and the unexposed groups, and it is an absolute measure. So they can be interpreted differently, and that's the point of these next two slides. So these are data from a hypothetical study looking at the incidence of preterm birth according to level of stress during pregnancy. So women were categorized as being stressed or not stressed, and then their delivery was assessed in terms of being a preterm or a full-term birth. And when calculating the numbers looking at the relative measure of risk, one calculates a value of 2.18, and that can be interpreted as that the risk of a woman delivering a preterm birth baby is 2.2 times greater if she's stressed during pregnancy compared to if she's not stressed during pregnancy. So again, the relative measure is a measure of increased fold or likelihood of the outcome occurring compared to in the exposed group compared to the unexposed group. So in contrast, you can calculate the risk difference. Again, if this is an absolute measure, again, incidence is calculated the same, or risk. However, now you're taking the difference or the delta between the two, and usually we calculate the incidence in the exposed minus the incidence in the unexposed. And when doing so with this scenario, we get a risk difference of 0.02, which can be translated into a percentage by multiplying it times 100. And we can then say the risk of preterm birth is increased by 2% for women who are stressed in their pregnancies compared to women not stressed. So when looking at relative risk, we concluded that there's a twofold increase in the risk. When looking at risk difference, we conclude that there's a 2% increase in risk. Now, those two can be interpreted slightly differently, obviously. And that's why it's important to understand what you're looking at if you're looking at a relative measure or an absolute measure. And then this is another example of that. So here you have data where the incidence in group A is 4 per 1,000, and in group B it's 1 per 1,000, giving you a risk difference of 3 per 1,000. But that calculates out to a relative risk of 4. So again, the interpretation can be different, and they're both correct measures. However, the values are different in most cases.